Uh, we welcome you all to this next webinar in the webinar series on capacity building on NPNCDs. Today we shall be discussing about an important risk factor for NCDs, that is air pollution. We have had webinars related to tobacco, alcohol, as the key risk factors. So today we are joined by our nodal officer for from the National Program for Climate Change and Human Health, Dr. Aniket Chaudhary, who is an eminent public health specialist and shall be discussing about the various factors which affect the interlinkages between the air pollution and NCDs, and what should be the role of the NCD nodal officers in mitigating the risks. Before I hand over to Dr. Aniket Chaudhary, certain things I would wish to highlight. When we discuss about air pollution, we tend to talk about the main pollutants such as PM 2.5, particulate matter 2.5, PM 10, ozone, nitrogen oxide, nitrogen dioxide, and sulfur dioxide. And these are pollutants which commonly originate from the vehicular emissions or the industrial processes or burning of the fossil fuels, which infiltrate our bodies through the inhalation. There are certain interventions which are required at the individual level as well as the community level to mitigate the risk. At the individual level, we can, as for the other risk factors for NCDs, we should encourage forms of physical activity, walking, cycling, yoga. Health promotion measures should be taken at the individual level, and the CHOs at the Ayushman Arogya Mandirs, health sub centers, health and wellness centers should play a key role in motivating their healthcare staff, ANM and ASHAs, to go to the community and educate people about this. With respect to community-led interventions, yes, reducing the pollutants in the air is one of the factors, and other things is related to um uh, im- strengthening the health facilities also, uh, with respect to capacity building as well as availability of infrastructure to mitigate the air pollution related risks emerging out of air pollution risks leading to NCDs. So with this, I would like to request Dr. Aniket Chaudhary to please take over and guide us through the session. Over to you, sir.
Thank you, sir. Thank you, Avinash, sir, for the introductory speech. I think it makes my job easier. So allow me few seconds to project my screen. So as sir was mentioning, before we go into the presentation proper, as sir was mentioning, when we talk about interventions related to environmental risk factor, broadly we classify into two parts. One, the mitigation aspect, which sir was mentioning, and apart from mitigation, we also talk about adaptation measures. So per se, mitigation, as we all know, is being under the nodal Ministry of Environment, Forest and Climate Change. So by mitigation, we mean, cutting the emissions at the source. It's kind of a radical treatment, if I may say. Whereas when we talk about adaptation measures, it's actually a coping strategies that we apply to the changing environment. As Saraf clearly mentioned about the pollutants, so it's not only about particulate matter, but with growing and evolving evidences, we can say the nitrogen oxide, NO2 or ozone, which are also very much, a risk factor for non-communicable diseases. So just to give you the idea or a snapshot of the burden of the risk factor due to air pollution, what are the organ systems that are affected? If you see the right hand side of the slide, you can see starting from the central nervous system to the cardiovascular system, the respiratory system, and growing evidences suggest that exposure in utero, that is during the pregnancy, exposure to these pollutants might lead to neonatal deaths as well. So this is the source of this data is the State of Global Air, the SOGA 2024 report, which is a very recent evidence that has come out of the global burden of disease. The IHME along with ICMR and other partners have conducted this study. And if I may read out the proportion of deaths, this is due to the mortality due to exposure to air pollution. If you see the proportion of deaths that are happening due to these specific diseases, if I may say, almost 40% of the stroke deaths, that is two-fifths of the stroke deaths are air pollution is a risk factor. The potent it is attributable to air pollution, exposure to air pollutants. When we talk about diabetic death, it's around 20%. When we talk about COPD, 67%, alarming figure. Two-thirds of COPD deaths are attributed to air pollution. And if you can see, 33% of neonatal deaths are attributed to exposure to air pollution. It may be a multi-pronged, but it is also attributed to air pollution. That is one-third of the neonatal deaths. So this gives you an idea of the health burden that these, environmental menace is giving us. So just to give you a broad outline, air pollution is the leading risk factor for death in India, and which accounts for around 21 lakh deaths annually. Air pollution is it is the leading risk factor which accounts for 2 million deaths annually in our country. And when we talk about segregated in a pollutant way, if you talk about the ambient particulate matter, it is the third leading risk factor. Whereas please stress upon household air pollution, which is the second important risk factor. So it's not only an urban phenomena, if I may say, our domestic activities that we undertake on a daily basis, that is also one of the important risk factor. And if you see the slide, it is household air pollution, which is ranked as the second most important risk factor for mortality. And when we talk about how are we exposed to, as per the Indian standards, if we see more than half of our country are living in a condition wherein we are exposed to PM 2.5 more than the cutoff, that is 40 microgram per meter cube. And when we talk about WHO targets, almost three-fifths of our population are exposed to uh, cutoffs not desirable as defined by WHO. When we see the right hand side bottom of the slide, if you see, which sir was already mentioning that, our residential activity accounts for around one-fourth of the total PM 2.5 exposure. When we link it to the number of deaths related to different activity, we always think about industry is the one of the commonest cause of, exposure. But if you see the right hand side bottom of the slide, if you can see, it suggests that 25.7% of the total outdoor PM 2.5 is attributable to your residential activities, that is burning of the fossil fuels. It's just a symbolic picture. And that is linked when we link it to the number of deaths. What is the actual number when the burden is concerned? How much percentage, 25.7% attribute to how much of the death? When it is converted or translated into number, it is whooping around 5.36 lakh, almost zero point 0.5 million. More than that, deaths are attributable to your residential activity, that is burning fossil fuel, which suggests the importance of shifting to the clean air, clean fuel technologies. So that's a nutshell. Vis-a-vis, if you see industry, the third part of the bottom of the slide, it's only 12.5%, 14.8%, which is accounting to around zero point 0.3 million deaths annually. So just to highlight that air pollution is no more a urban phenomena or urban a city phenomena. It's equally affecting the rural household as well. You're all to be refine it to saying that it is more of the activity that you undertake at your day-to-day basis. Moving to the next slide, which are the diseases or what are the interlinkages between NCD and air pollution? Some of them have already been highlighted, but to be more precise, chronic respiratory disease, as I was mentioning, the COPD is the chronic obstructive pulmonary disease, the acute exacerbation of the asthma, lung infections. So these are the areas. So it not only affects the general population, but to be precise, the vulnerable population are the extremes of ages, that is children and the geriatric population more. And when we talk about air pollution, one only thinks about respiratory difficulties. But to be very honest with you, air pollution accounts for approximately 48% of the cardiovascular disease deaths in India, which includes the ischemic heart diseases as well as the stroke. So almost half of the cardiovascular deaths that are happening across the country are being attributed to air pollution, nearly half of the deaths. This is the data source is the same State of Global Air Report 2024. The percentages and the rates are very well documented. Cause specific rates and the metrics are documented in the Global Burden of Disease 2021, which was published in 2024. Newer evidences also suggest that exposure to these pollutants can also lead to type 2 diabetes, certain neurological disorders like Alzheimer's and Parkinson's disease, and also attributed to cancers. Cancer in terms of skin cancer, in terms of lung cancer, bringing about some mutation in the genetic mutation also. So it is no more a respiratory or a cardiovascular system that is being affected by exposure to air pollution, but also growing evidences suggests that it is yielding to type 2 diabetes, various types of cancer, as well as neurological disorders like Alzheimer's and Parkinson's, wherein the olfactory lobe of the CNS is affected prematurely. So these are some of the growing evidences that we have which links air pollution with non-communicable diseases. Now, as sir has already mentioned, that there are two programs as we all know. There's a non-communicable national program for non-communicable diseases. There's a program for national program on climate change and human health, and we also have sustainable development goal targets. So this slide is borrowed from Hriday. I have borrowed it from the Hriday. I have taken it from their sources just to highlight, to show you the targets that are there for set for various program, be it a global target in terms of sustainable development goal, or be it the target of national programs like NCD or NPCCHH. The targets are more or less aligned, which also suggests that both the program are working together at the national level, and we promise you that at state level and or district level, be it in terms of community or a health and wellness center or Ayushman Arogya Mandir, we have to work together to reach these targets. So let me just list out the targets. I will just read it out for all of us. So SDG target, Sustainable Development Goal target 3.4 suggests that we have to reduce this premature mortality from NCDs through prevention, and also to promote mental health and well-being by 2030. In similar line, when we see the NCAP target, NCAP stands for National Clean Air Program, which is being run by Government of India in around 131 cities, which are non-attainment cities, which have chronically shown high level of particulate matter 2.5. So their target is also set as reducing this 40% reduction in annual level of particulate matter, fine particulate matter 2.5. Now they are also bringing in black carbon targets as well, apart from PM10, PM2.5, and also black carbon targets. So this is the target that have been set by NCAP program. In similar line, if we see national NCD target, what our program suggests, our target is 50% relative reduction in household indoor air pollution. As I was mentioning previously, that it is no more a urban phenomena. The household indoor air pollution, be it a rural household, be it an urban household, we have to reduce this by 50% by 2025. Similar line, if you can see, when we translate it into the outcomes, 25% relative reduction in premature mortality in line with the SDG targets, if you can see, by 2025. So how can we do that? We have to do, ensure access to clean energy in homes by 2030. This is SDG target 7.1.2. That is to promote the clean energy in homes by 2030. For that, Government of India has set out various programs, various initiatives, one of which is Pradhan Mantri Ujjwala Yojana. And I think this needs to be promoted in line with Ministry of Renewable Energy. So we all have to work together to bring this into reality. Similarly, if you can see SDG target 7.1.2, ensure access to clean energy homes by 2030. So what are the strategies that we should take care of? In terms of policy and governance, if you can see the bottom and the left hand side of the slide, strengthen the air quality standard and enforce compliance. So India has defined their air quality standard, and MOEFCC is in process of uh, cutting down those standards and reducing this standard. I would say making them more stringent. So the cutoffs are in process of revisions. That already the policy decision has been taken and his work is under progress. What we can do? So we have representatives from all the three tiers, starting from Ayushman Arogya Mandir, then district level, then state level. What we can do is that integration is going to happen and it's happening at the national level. In similar line, we would also request our state colleagues who are there. We also have from National Program on Climate Change, we have program officials identified. You are also aware of it. We are requesting you to work hand in hand. We have developed the state specific action plan and we are in process of developing the district action plan. And I assume NCD also have their own plan. So we need to integrate this plan. And at national level, we are trying to address these environmental risk factor in terms of, the COPD guideline that is being developed for medical officers. We're trying to chip in with air pollution as a risk factor, important primary risk factor, owing to the burden that it upholds. In similar line, as we are talking together, so we need to promote the intersectoral collaborations. So the stakeholders in terms of mitigation, stakeholder in terms of adaptation must come together and play their role. So if you can see the third part of the slide, intersectoral collaborations for cleaner transportation, energy, industrial practice, these are all mitigation players. But when we talk about adaptation, there are various national health programs, relevant national health program, which we can target to work together. For example, both of us can work together. Along with that, we can also chip in the child health program division. We can also chip in the Rashtriya Bal Swasthya Karyakram, Rashtriya RBSY. We can also involve the adolescent health program. We can also involve the healthcare elderly, the national program for healthcare of elderly, because the geriatric population is also termed to be a vulnerable population. So these are the areas where we can chip in. I'll be giving you some examples of the work that has already been done and it has to be taken it forward. So in terms of developing the modules, their training modules, in terms of developing the capacity of the health workforce, in terms of designing community based program where we can educate the mass, very important element. Unless and until we reach out to the community and educate them or make them resilient to this risk factor, things would not happen. Ownership will not come until and unless the community gets involved. Today the immunization program is successful only because there's a awareness drive that has taken place. Mother, children, they are actually know the importance of vaccination, so that's why they reach out to the facilities and demand their services. Such kind of demand driven services needs to be built up, and I think program is doing very well in terms of spreading it to the doorsteps of the community, implementing the services through the Ayushman Aragya Mandir, wherein we need to figure it out to include the environmental health screening as well. So the services that we are delivering, we need to be educated enough to keep a screening in terms of environmental health factor, risk factors. So when a COPD comes to the OPD, our medical officers who is attending or our community health officers who is attending the patient as a first referral point should also screen the patient that it might be a cause of air pollution related illnesses as well. So that's where our we should be very much careful about it. In terms of technological innovations, if I may say, there are various applications which documents the air quality indexes. So that can be promoted across. I mean, we can spread it across that there are applications like Samir, SAMEER, SAFAR, SAFAR, which give you a real-time picture of the air quality index. And I think recently Google has also brought in air quality monitoring into their maps as well. So once you look into the Google Maps, you can see very well what is the status of your air quality in the vicinity where you are staying or where you are working. So such kind of development is ongoing, and program NPCCHH program has developed API, and wherein we are pulling out data from Indian Meteorological Department, Central Pollution Control Board data, Such kind of data forecast can also be shared at the health facilities as well. For example, if you can arrange a display or something, if you can just write in the desk or the board that is available in your facility, ki today's air quality index stands to be say 200 or say 50 or whatever it is. So that will actually aware the people who are coming to your OPD about the risk reduction strategies. Even you can have a short, counseling session wherein you can teach them about the air pollution risk factor as well. We are also working with the NUHM program. Similarly, we expect at the national, state and the district level, we can also work together to mobilize some resources and we can invest in some urban planning initiatives. Apart from MOHUA, that is Housing and Urban Affairs Ministry, we can also work within our health system, the program that is NUHM, National Urban Health Mission. And if you move to the right of side of the slide, you can see about public awareness and behavior change. This is the most important area, and I feel like it has to be explored a bit more. So we need to educate our community. We need to send them some alerts or kind of a messages that happens during the earthquake. If you see, there's an alert being sent by the NDMA, National Disaster Management Authority, that the flood is going to come, or maybe there would be a cyclone. Such kind of alert mechanism or such kind of risk reduction strategies, the early warning system, if that can be reached out to community, it will help to educate them and minimize the impact of these climate change strategy. So we need to educate the community. We need to encourage the use of personal protective measures such as mask and air purifiers. Though we do not, I'm not promoting air purifier here per se, but this serves as a purpose, at least the respiratory etiquette and the personal protective measures can be utilized during the crisis period when the air quality deteriorates. And we need to have reduce the carbon footprint. So we need to shift to clean airs, that is maybe the program is promoting for solarization of the healthcare facilities, also the conversion of non LED to LED light, kind of developing a rainwater harvesting at your healthcare facility to reuse the rainwater, kind of energy audit whether we are using the energy judiciously or not. So these are some of the strategies which I wanted to highlight. Just to show you the alignment of the program objectives, if I may say, for both the program, the left hand side is the non-communicable disease program, the right hand side is the climate change program. And if you see, both centers around all the broad five objectives that we target as a whole. So if you can work together, these objectives can be met easily. For example, if I may say, capacity building, you can see it is there for both the programs. When we talk about health sector preparedness, there comes supply chain management. So it is applicable for both the program in terms of health sector preparedness during the crisis period. When we talk about educating the mass or educating the healthcare facility or capacity building of our health workforce, we are in tandem, right? So health promotion through behavior change, not only with the community, but with the healthcare functionary at first to begin with. And intersectoral coordination, which we are yet to explore, going beyond our health ministry. So we have started exploring with Ministry of Art Science, Ministry of Women and Child Development, Ministry of Panchayati Raj Institute, which actually the local help government, if I may say. So we need to utilize them at the fullest. States like Kerala have done a wonderful job. They've created a community care triad, wherein there's a representation from the community, there's a representation from the local self-government, and there's a representation from the healthcare functionary. So each and every individual who is at risk is being treated by their, triaged by these community triads. So that model can also be explored where applicable. So just to show you the objectives of both the programs in terms of capacity building, in terms of awareness raising, in terms of health sector preparedness, in terms of intersectoral coordination, almost we are in alignment. So similar alignment, similar relationship has to be built out down the line as well. Moving to the next slide, again, the objectives of the non-communicable disease program, if I may say, in terms of promotion, screening, capacity building, research protocol, evidence-based standard treatment protocol. We follow the ICMR treatment protocols, uninterrupted drug and logistic supply, which is very, very important when we service delivery is concerned, and task sharing and people centered care. This is the fulcrum of the service care delivery, people centered care. We are bringing the services to the doorsteps of the patient. We are organizing outreach camps. We are building a health and wellness center, Ayushman Aragya Mandir, catering to a population of 5,000 odd population, converting the sub center, upgrading it to health and wellness center, where round the clock availability of CHOs, round the clock availability of doctors at the HWC PACs as well. This triangulation that is happening in terms of data, the portal speaking to each other, the NCD program, we can develop the an API wherein we connect our surveillance with the surveillance of the NCD program as well, until and unless the digital advancement happens. But we can have a monthly meeting wherein the climate change program officials discuss their issues with the NCD officials as well. So such kind of state initiatives or district initiatives or local initiatives can be encouraged, so that regular sharing of data happens. There can be a comprehensive service delivery to the community, to the individual as well. We can have a joint monitoring platform wherein we can prepare a team and then monitor both the programs, the both, or I would say, relevant programs to the whole, because most of the places I know the officials might be individual looking after all the programs, relevant programs. For example, district surveillance officer looking after the IDSP program, maybe also looking into the NCD as well as the climate change program. So a joint program monitoring plan can also be developed. And I was talking about multi-sectoral coordination linkages with other national programs. So this is, day by day as we grow old in this program, this would become a more relevant point, because, health alone cannot do it, or one national health program alone cannot serve the purpose, because these are intricately linked to each other, right from pathophysiology to service delivery and monitoring the follow-ups also. Everywhere, in the resource constrained country like India, we need to work together to give a better service delivery. So these are some of the areas where we can chip in, but I would like to highlight one specific example. This is one of the package of services that was mentioned in the document, which we have already started working on. And since we have a representation of three tier of, say, community officers as well as district officials and state officials are there. So just to give you an idea on an example, if you can see, we are doing CBAC risk assessment. We are doing this checklist. We are filling up this checklist with help of the frontline health workers. Wherein, if you deeply look into the checklist, we have targeted very few areas wherein it is relevant for both of us. So we are targeting at individual level and community level. So the relevant areas, if I may highlight here, if this is a snapshot of the community-based assessment checklist, wherein you can see we have targeted up the smoking practice. So active and passive smoking, which might lead to these NCDs. And talking about air pollution, if you see, the risk factor for COPD has already been addressed. So what we have tried to figure it out is whether the type of fuel used for cooking, whether we are using a firewood or not, whether there's a burning crop residue that is happening or not, whether we are using cow dung cake or not, or we're burning kerosene or coal or something like that, or how much have we shifted to LPG or the clean sources or not. And we have also talked about occupational exposures. So certain things which are relevant to both the program has already been addressed in the checklist, and data are being collected religiously by the frontline health workers and given to the concerned authority also. But what next? How are we utilizing these data? There is a task force for every program, and I hope there's there for non-communicable disease and climate change as well. So the bureaucrats, the political leadership, I mean, they meet through our program on a monthly basis periodically. If there are certain issues which can be taken up to those task force meeting as well, the district task force or maybe the state level task force or maybe the governing body meetings that happens, whether there's an issue related to occupational exposure, whether there is a poor penetration of Pradhan Mantri Ujjala Yojana, or there's some clustering of cases that is happening at a particular geography, trying to find out the reason behind it, and it is being attributed to certain uh, you know malpractices related to environmental hazards. So we can take those issues. I mean, there are provisions which the program is supporting by giving you the ambient data that is required to convince these bureaucrats or the politicians or the policy makers, if I may say. So please utilize this data right from field level. This is being done at the field level. When we move upwards at the PHC or the Health and Wellness Center or the Ayushman Arogya Mandir, these are the two identified areas where we can talk about not only NCD but NCD attributed to these environmental risk factors. Now, the medical personnel who are there must be very well aware of the epidemiological triad that we used to study in community medicine park textbook. We used to study the epidemiological triad, which talks about agent factor, host factor, and the environmental risk factors. So most of the diseases have only talked about agent and host factors, and environmental risk factors was not so much given an importance. But with the growing evidence which we can see in the burden distribution of the SOGA report, State of Global Air report, you can see the attribution of air pollution to the risk factor. Now it is the correct time when we talk about air pollution, we talk about heat related illness, and try to build in the behavior change amongst the vulnerable community at all. And we can also talk about confirmation of diagnosis, treatment initiation, in terms of management of NCD. But how can we reduce the risk that is being imparted by these environmental risk factor? So it's kind of a referral linkages can be developed in terms of both the program, in terms of the hierarchy of facility that is being there in the organogram of the program. So these are the two areas where we can chip in when we talk about at the PAC level. In similar line, in CAC and SDH, we can also talk about health promotion, similar line confirmation of diagnosis, in terms of management of cases of NCDs and regular follow up. So we do follow a treatment protocol. Every facility might be following their standard treatment protocol when it talks about COPD, when it talks about bronchial asthma, kind of uniformalizing the management services. So that's what we are thinking about it. In similar line, if we talk about district hospital, again we can streamline the diagnosis, management services, health promotion, and behavior changes at the counseling session that are happening at NCD. We can also talk about dedicated day about the environmental risk factor, of which air pollution is one of the very important environmental risk factor owing to the burden that it imparts. In similar line, medical college and tertiary care centers as well, the same line we can talk. So basically the idea is about supporting the program in terms of capacity building, in terms of preparing standard guidelines and protocols, support in terms of supervision, monitoring, and evaluation, and also evidence generation in terms of operational research. So I think I would stop here with this. I had tried to communicate my thoughts on interlinkages between air pollution and NCD. So if there are any questions, over to you, Avinash sir, and the NCD team,
Sir,
Dr.
thank
Shweta.
you. Thank you for this comprehensive presentation and highlighting the various strategies for the mitigation and adaptation, such as policy governance, health system response, technological innovations, and public awareness. How you have rightly emphasized that how the immunization program has picked up due to the behavior change due to intensive public awareness campaigns, and how since air pollution being one of the risk factors for NCDs, how the integration and multi-sectoral coordination among various programs through a whole of government approach can help us address this challenge. Then you also discuss about the environmental health screening. So as a part of CBAC forms, although certain data is already being collected, and you talked about the utilization of data, how this can be better utilized so as to bring about changes at the community level or at the individual level. And yes, we are also in a process, as you are aware, that framework, joint framework for NCDs and climate change with reference to air pollution. So we are also in a process of having a collaboration in this regard. So with this, I think we have already crossed the time for the same. Maybe next time we can connect for questions and all, because this is a monthly. We are twice we are having, and then maybe we will have a repeat discussion on this topic sometime, maybe 2 3 months later, so we can have discussions later on. So thank you for joining us, sir, and thank you for highlighting all the important points. And for the state nodal officers and district nodal officers, although some of you might be looking after the climate change program as well, so otherwise you can discuss. There are state-specific action plans for NCD, for the climate change, and the NCD program officer. So both of them can sit together, and how they can utilize the data from CBAC form, and then bring about in community level interventions, or individual level interventions, what they can do, so that the NCAP targets or the national NCD targets can be met. And just before I close, just one more point I wish to highlight, that we tend to think that this is an urban phenomena, but then yes, it is as much as urban. It is same goes for the rural household, because indoor air pollution is a major risk factor in the indoor households, in the rural households. So that also, so this makes it relevant for all across regions, urban or rural, whatever may be the case. So thank you everyone for joining. Thank you, sir.